going to be doing a shoulder exam. My name's Bob Spooler. I'm the founder and director of Meducate Academy. We provide associate clinical educators to the health professional industry. And my associate today is Pete Gorman, clinical lead at Wolverhampton University, who's kindly agreed to allow me to do a shoulder exam on him. He has some pathologies, and we'll have a look at those in a moment. My job as an ACE is not to talk about pathologies in any detail or to talk about diagnosis. I'm simply here to help students go through the techniques that will allow them to examine body systems today. It's the shoulder. So, Pete, thanks for agreeing to doing this today. Do I have your permission to examine your shoulder?
Yes.
Okay, it's always important to get consent. I'm not a clinician, but I'm still going to get consent. I'm going to be touching Pete, so I'm going to wash my hands, as you would do, making sure you use the correct method, and make sure it's a thorough washing of the hands. And today the examination is going to involve me asking you to remove your upper garments. Would you be able to do that? And would you need a chaperone before you do that?
I'll remove my upper garments.
Okay.
And no chaperone, thank you.
The student can also take into account, while the patient's getting undressed, do they have any problems moving the arms or the upper limbs at all in any way? Because often some shoulder pathologies can prevent ease of movement. I can see that Pete doesn't have a problem taking his shirt off at all. Right, Pete, thanks very much for doing that. So, as in all musculoskeletal examinations, the names should be look, feel, move every single time. That's the first thing I'm going to do. I'm going to look at Pete in an anterior perspective here. And I notice that he has no asymmetry of the shoulders. The shoulders are perfectly symmetrical. I do notice a large scar. Was this some sort of operation you've had?
I had a complete pectoral avulsion repair.
And that's fine now for me to move that. There's no pain or anything.
Minimal pain.
Always, again, check that the patient's not going to be in pain. And if you do notice a scar, no matter where it is on Pete's torso, I would have mentioned it. I noticed that there's symmetry, no scars on the left-hand shoulder, no swelling, no wasting, and no apparent wasting. Pete, have you lost any weight on one arm because of this operation? Did you notice any weight loss? So, Pete, I'm going to obviously ask you to move that shoulder. Does it cause you any pain, and is there any problems with that at all?
At the end of range of motion, there is a little bit of pain.
Okay.
It won't stop me significantly. You mentioned bulk.
And bulk wasting,
I think there's a slightly larger deltoid here and a little bit of weakness on my back, which you'll see when we actually move it through.
When we come to move it. Okay, thanks for that, Pete. Also notice you've got a slight scar here. A little mark there. Nothing else that I can see.
I believe this was a paediatric procedure when I was born.
Okay, so always take into account anything you can see. The examiner's always like that. It means I'm actually looking at the person. I notice tattoos as well. Okay, so Pete, I notice the clavicles are symmetrical. Can you just turn to the side facing there 90 degrees? I'm looking now at the side of the shoulder, the lateral aspect of the shoulder, and again I'm looking for swelling, wasting, scars, and any fasciculations. No asymmetry. I'm also taking into account obviously the cervical spine. That's really important. And I notice if you just look forward for me, Pete, cervical spine's got normal lordosis, there's no kyphosis. So we can just turn again 90 degrees, Pete, thanks very much. Again, as well as looking for symmetry, swelling, wasting, fasciculation, involuntary tremor, anything else I can't see, any wasting that is apparent. I'm also, of course, looking for scoliosis in the cervical spine. This would be a curvature of the spine that would affect problems with the shoulders and vice versa. Everything looks good there. And finally, another 90-degree turn, Pete, to you. That's it. Thanks very much. I'm now looking at the lateral aspect of his left shoulder. And again, no cervical lordosis of any, no kyphosis, no problems with wasting. And actually, yeah, I can see the shoulder is slightly different to your right shoulder, Pete. There is a significant difference with the deltoid muscle at the side there. So anything you see, you mention, and face back to me. So that's the look phase of the shoulder examination. So now what I'm going to do is move towards feel, palpation, okay? Be quite firm with your palpation. If my patient was a frail 90-year-old gentleman, I'd be a little bit more careful, but Pete's quite a big strapping fellow, and I can therefore go in with a little bit more pressure than I would with an older person. I'm going to start here, the sternal notch, Pete. Now normally we would check one shoulder against the other. You always compare and contrast the two. For the purpose of this examination, I'm simply going to do Pete's, I think I'll do Pete's right shoulder. That keeps me away from the one that had the operation, okay? And actually, if Pete was suffering any pain in the right shoulder, I would start, in the left shoulder, I would start with the right shoulder. Okay, so I'm moving on to palpation. This is where I'm going to apply pressure to the bony prominences around the clavicle, the shoulder, the acromion, the glenohumeral joint, and of course the spine of the scapula and the border of the scapula. I'll also take into account palpation of the cervical spine, both centrally and paraspinally, to make sure that I've covered all of those areas. Palpation should be firm, but not rough, and it would depend on the obvious physiology of the patient. If Pete was a frail 90-year-old man, I'd be proceeding with a little bit more caution. But as Pete's a young man in his 20s, a bit of flattery doesn't go too far with the patient. I'll put a little bit more pressure on than I would with an older person. So Pete, I'm going to start palpating now. I'm going to start at the sternal notch, and I'm going to palpate along the clavicle. Okay, you notice I'm using the tips of the fingers. I don't use piano fingers, you're not going to feel anything. And I'm trying to follow the anatomy and the structures that underlie the shoulder itself. You just turn for me, Pete, slightly. And you can see I'm working my way around the edge of the acromion here, rather than just simply over. Common mistake students make is to go straight over the acromion and they miss out all of this area here, which often is a seat of pain. How's that feel, Pete? No pain? No? As I'm moving around here, move for me again, Pete, thanks very much. I'm just putting my thumbs in deep so I can really get a sense of what structures are underneath the skin here. And the more bulk someone has, muscular bulk, the more difficult it is to find these bony prominences. Okay, I'm now coming up to the spine of the scapula, which runs over the top here, and that takes me down to, if we just turn again, Pete, we can just demonstrate here, the scapula runs around here, and I'm just going to follow the edge or the border of the scapula all the way down to the apex of it here, and I'll just gently palpate over the muscles here. Any pain on those movements, Pete?
No,
okay.
not at all.
I'm now going to just check your neck, okay? So don't be alarmed, I'm just going to press on your spine here. The cervical spine is quite delicate, so I'm going to press quite gently, but I still need to feel the structures that underlie the vertebrae here to the C7. And then keep your head upright for me, Pete, thanks. And then I'm just going to press, as you can see, my thumbs paraspinally down again to about C7. Okay, Pete. So that concludes palpation. There was nothing that I felt that was unusual. If you were to find anything unusual and you're comparing one against the other, you mention this to the examiner or the clinician present. Right, Pete, so now we come to movements. This is going to get me to do some movement, so I want you to follow me. This will help. Okay, so if we just face forward like so, okay? And what I'm going to do, and all the time we're doing this, I'm keeping focused on the affected limb, okay? And I'm focusing on the right shoulder at the moment, okay? I want you to put your hands down by your side, Pete, and you're going to, but not yet, raise them all the way up and then all the way back, down and back. This is flexion and extension. Nice and slowly, Pete, up you go with the hands, please. All the way up, and as far as you can go. Is that as far as you can go? Good. I notice that there's slightly less flexion in the one with the scar. And lower the arms down and take them all the way back. That's good. All the way back, and then back down to a neutral position. Okay, so that is flexion and extension. You can, of course, and I encourage you to do so, relax your arm, is take the movement through yourself, all the way through, as high as you can, and then back again. And of course you do this with the other limb as well to compare. Okay, so that's passive and active. We also now need to do adduction and abduction. Okay, now normally obviously a patient doesn't understand these terms, so I would demonstrate to the patient, cross the arms in front like this, Pete, but not yet do this movement to the side and all the way back, please. This is abduction and adduction. If you just do that now for me. all the way up. Again, I'm observing the shoulders and how they move. And remember, quite a lot of the shoulders at the posterior aspect, so it's useful to walk around the patient as they're going through these moves, but not get struck by them, obviously. Okay, and all the way down again, Pete, thanks. That's great. Okay, so obviously all of these moves need to be done passive and actively, so again, I'm going to control this, let the patient relax, Pete, thank you very much. The hand is on the top of the shoulder here, so I can feel for any crepitus. Okay, and there doesn't appear to be any like this. Let me take the weight, Pete, thanks very much. Patients will often help you do this, so it's really important that you tell the patient to let me take the weight of it. You want to move it, passive and active. Okay, Pete, if you just put your hands in front of yourself like this, and what we're going to do, I'm going to ask you to turn them out, but keep the elbows in place here and turn them out like this. And if you can just sort of face me slightly this way and just turn them out like that and then back across. This is external movement of the shoulder, and that seems symmetrical. One more time, Pete. Not quite symmetrical because of this problem Pete's already alluded to earlier on. So he's got slightly more external rotation on this side. And of course, again, we can do this passively as well and actively like so. Okay? So again, check one against the other. And then finally, Pete, what I'd like you to do, one hand at a time, you're going to put your hand as far up your back as you can. Okay? And see how far. Now I'm going to do this with both because I want to compare them so the students can see. Okay, so if I'm looking here, Pete's approximately, and that looks like it's about a T5. Okay, so can you do it with the other hand now? Oh yeah. Now you see, because of the operation that Pete had, there's restriction in movement. This is in one of the lumbar vertebrae, so there's a significant difference. And it's important, you know, when you're examining the patient to do this. This is internal rotation of the shoulder, and Pete has less internal rotation on the limb in which he had the operation. That's quite significant change there. Okay, I'm not going to do that passive and active because basically I'll be putting his arm up his back. Okay, so again, just to show the patient that you're not going to cause them any pain. I'm going to do a few things now to check the power of these movements, okay? I'll be using technical terms, which I'm sure you understand, and hopefully the listeners will. What I'd like you to do is turn your thumbs down like so, Pete, okay? And we're coming in at this sort of angle, about 30 degrees. Okay, Pete, I'm going to push against your hand, your wrists like so, and I want you to resist them. Okay, and we're checking power, one against the other, and that appears to have equal power. This is testing the supraspinatus muscle. If you put your hands back in that position like we had them before, that's good. Stop me from pushing them in again, and we're checking infraspinatus muscle strength. And then finally, okay, we're going to have you put your hand low on your back like this, Pete. And I'm going to push a little bit lower so it's more comfortable. That's it. You're going to push against my hand as hard as you can, okay? And that's testing subscapularis. On the other hand, Pete, I'll just compare it. Push against me. That's good. And actually, that's equal. So the power's good on all of those. 5 out of 5 on power. It's really important to check power. Students often miss this in a shoulder exam. Okay. Now we move to the special tests, NEARS, Hawkins-Kennedy and the SCARF. NEARS and the Hawkins-Kennedy are a test for impingement, and the SCARF test is to check for AC pain, acromioclavicular problems. Okay, the first is the NEARS test, where we turn the thumb down, sometimes called the empty can position. I don't know why, I've never poured any drink down like that. I'm going to put my hand on the top of the shoulder to feel for crepitus, and I'm going to ask the patient, Pete, can you let me take the weight of the arm? This is really important. Patients often try to help you with this. You're moving it, not the patient. And we lift the arm nice and gently all the way up, keeping an eye on the patient to make sure they're not in pain. And Pete's helping me there, and I let it drop all the way down, nice and slowly. We then take it beautifully into this position here, okay? Again, I can feel the shoulder here, and I can also importantly hold the weight of the patient's arm. So I know that Pete is now relaxing his arm. Ensure though, and this is really important, that the arm is kept parallel to the floor. This position's absolutely key, okay? Don't let it sag or drop. Supporting the arm, I then internally rotate. Again, watching the patient to make sure they're not in any pain or discomfort. And after 3 or 4 possible rotations, I place Pete's hand on his opposite shoulder. Again, I'm holding up the elbow here because I want this to stay on the plane parallel to the floor, like so. Can you take your arm over your shoulder? This is a check for the AC. And I can see Pete doesn't seem to be any discomfort, so I'm just going to give it a little push to see how much more extension I can get on it. Very good, and then relax Pete. And of course I'd also perform the same thing on the other arm. I'll then thank the patient and ask him to put his shirt back on, and that's the end of the shoulder examination.